Assalamu alaikum. I will share with you a couple of cases under title of OCT guided PCI. In our hospital, the military hospital Dahran, we are using the OCT since 2013, and since that time we fell in love with OCT and we are using in most of our complex cases. My first case, this is 62 years old gentleman. He is diabetic. He developed anterior STEMI. Patient was taken directly to the cath lab where we found this RCA distal lesion and some retrograde filling to the LAD. And as expected, the LAD is totally occluded at its mid segment. So we proceed for PCI to the LAD. First wire, then export catheter, which is still we are using most of cases of STEMI, and restoration of flow. Then we have good result after stenting and post-dilatation. So what to do for the RCA? We staged the RCA after 1 month. We called the patient and we plan to do PCI to the distal RCA in the PDA. Although it's a small vessel, but the patient was having some chest pain. So we got a wire, a small balloon, 2015, and then a stent, 2022 stent, inflated, deployed, and then post-dilated with 2.5 at 16 atmosphere. And this is the result after stenting and post-dilatation. It looks fine. The patient is happy. My team is happy. You can stop. So coming the question, do I need to do anything more? In such small vessels, especially when I'm using a very small stent, I'm preferring to do OCT to make sure that the stent deployment is perfectly okay. So this is the OCT I did, and as I expected, there is some malapposition at the proximal segment of the stent. I'll go slowly. This is a distal edge, which is for 2.0 stent is perfectly okay in this small-sized vessel. More proximally, the stent is fine, but very proximal of the stent is grossly malapposed. Measuring the proximal reference segment, it seems that it's 3.0 millimeter vessel. So the next wisest step is to take a 3.0 balloon and to post-dilate this stent once more. Unfortunately, and this happens, during removal of my OCT catheter, my wire was dislodged, maybe because my wire was in a side branch, not distally enough in the distal part of the vessel. And this is the picture now. I have angiographically good result. OCT showed me there is some stent malapposition, but angiographically I'm looking fine. So what's the next? I will respect the OCT. I went for rewiring, get the wire back, and I went easily inside, and I went inside the branches, and then I have my wire down in the distal RCA. Then my balloon is not coming. I'm taking non-compliant balloon 3.0 as measured by OCT, and I cannot cross. Trying gentle, I cannot cross. So what should I do? Should I get a guide liner to improve my support? Should I take a body wire to give better support? Should I try smaller balloon? This is 3.0 balloon. Or should I repeat the OCT? And what I did is OCT. You can see here the OCT run. The distal port, I'm inside the stent, and see approximately how it looks. I will show it slowly. This is distally. There is a catheter there, and the wire is still inside the stent. And the same here, same more proximal, but very proximal at the area of malapposition. My wire, my catheter is under the stent, beside the stent, not inside the stent. And this is a longitudinal OCT showed here. You can see in this movie. My stent is in the proximal part is behind, my wire is behind the stent. Another rewiring, and then repeat the OCT, and still my catheter, you can see here the catheter is outside part of the stent. And this is very good for the OCT that tells how low profile is this catheter. I can go behind the stent, through the struts, and then going down in the vessel. Taking more and more time, making bigger loop of the wire, I could recross again and repeat the OCT, and this is a picture I have. I can see my struts on both sides of the catheter, so I am perfectly inside the catheter all through. Then I can advance a balloon, 2.5 balloon, with little difficulty because definitely there's some deformity at the proximal port of the stent. And then a 3/10 non-compliant balloon at 16 atmosphere, and this is the result after post-dilatation. It looks better. The stent looks funneled, especially proximally, and this was confirmed by OCT. The stent struts are well opened everywhere, even at the proximal edge. After this, usually I'm doing a 3D reconstruction of the stent to make sure I don't have any deformity, longitudinal stent deformity, or stent fracture after aggressive post-dilatation. Case number 2. This is a 56-year-old gentleman. He is diabetic, and he had PCI to the distal RCA and presented this time with non-STEMI. Patient has patent stent now in the RCA and has tight lesion in the LAD. This is the lesion in the LAD. So let's go to PCI, this LAD, first ballooning, and then drug-eluting stent, 2.526. It looks fine, but it needs more post-dilatation, then post-dilatation by 325. And this is the result after post-dilatation. If you can notice at the distal port of the stent, there is something. Here, I'm having intra-stent filling defect. So what is this? Is this a thrombus, embolized plaque after post-dilatation, edge dissection, but this is not at the edge, it's inside the stent or others. So coming to the answer, I'm going to OCT. Usually it gives me the answer. In this case, I have this filling defect inside, but I don't know what is this. So distal edge of the stent looks fine, but there is little crowdness of the struts. Then this is a filling defect. Proximally, the stent looks fine, and more proximally, stent is malapposed. This is a longitudinal OCT showing this filling defect in this cross-sectional area, and the 3D OCT. This is a picture I had. I have a stent fracture. This is why I'm having this filling defect. So I have a stent fracture at the distal port. I'm having a malapposed stent proximally. So what to do? I measured the area of the stent fracture by OCT and decided to stent inside the stent with 2.514 stent. And then the filling defect disappeared, post-dilated. And I took a bigger balloon, post-del in the proximal segment. And it looks better angiographically, and this is the OCT result showing better stent deployment, and longitudinal OCT confirmed this. Angiographic result looks fine, and this is 3D after having 2 stents. You can appreciate here double layers of the stent at the segment which had the previous fracture, and 1 layer proximal. This is the angio after 1 year follow-up, and the patient is doing fine. My take-home message is OCT is not, and I guess it will not be, indicated in routine PCI cases, yet OCT is a magic tool to give clear answers for angiographic uncertainties and pathophysiological dilemma. And when you have a question in the cath lab, you have 3 ways to go, either to go blindly, angiographically, use ultrasound to guess, or use a light to see with the OCT. And thank you.